Okay, this is cuff monitoring. First off, you're not going to see anything. Get closer. You guys all probably want to come closer to get me to see it. Okay, this is cuff monitoring. We're going to do both techniques. We're going to show you MOV, and I'm going to show you MLT, minimal occluding volume versus the minimal leak technique. Okay. Now the first one I'm going to show you will be MOV, the minimal occluding volume. And the first thing you should know about minimal occluding volume is that the results are recorded in volume, so it would be CCs. Okay? MLT, the minimal leak technique, will be recorded in centimeters of water pressure. So MOV, whenever someone asks you what the MOV is, okay, the technically most correct would be 5 cc's or 3 cc's or whatever mLs. Okay? Now, a lot of hospitals use a combination of both, so don't be surprised if you see something where 1 minute they're using volume and the next minute they're using pressure. Okay, but for true actual purposes, MOV is minimal occluding volume. And what you need to do before you check the cuff pressure, and usually cuff pressure is checked once a shift, or if you can hear the patient gurgling on a breath, or at worst case they're talking to you, you know something's wrong, you need to check the cuff. If you look at your peak airway pressure on your ventilator, you look at your tidal volume, and those numbers are down from where they were before, then there's a chance that there's a leak, and you will need to check the cuff. So even though it says once a shift, that's all the official, and after that you will need to check it as you see indicated. Now the first thing you do before you check any cuff is, as always, you will need to suction out the mouth, because you don't want any of these secretions going down and aspirating. It's just like intubation all over again, and extubation. It's the same principle. So you would clean them out, clean out the mouth first, okay? And at that point then, for the MOV, you would need to attach a syringe, okay? And the other thing you would need to do is with your stethoscope, you would need to listen again on the tracheal area. Okay? Now when you attach this, okay, you will hear some noise. Even if the cuff is completely full, you will hear some air moving around. Why? Because the cuff is soft. So some air, it's not surprising to hear the air moving through the tube, okay, and around the cuff. Sometimes you don't want that, but it happens. Okay? So it'd be very rare that when you put your stethoscope here that it's silent. You'll probably hear some movement of air. Okay. What you're listening for, though, okay, and with MOV, okay, then you would simply add air. Okay, zoom in on my hands. Add the air until you hear no leak. When you withdraw the air, you'll hear gurgling and bubbling and all about it. It sounds very turbulent. That tells you there's a leak. The other check would be once the alarm starts sounding on your machine, the low pressure alarm, the low volume, that would also tell you you've got a leak. So then you need to seal this up, listening, until all you hear is a laminar flow, nice smooth little bit of flow. You look over at your machine, your volume should be back to normal. Your pressure should be back to wherever it was before. It may be even a little higher because it might have been a leak before, but you will follow what I'm saying. It should not be less. Okay? And minimal occluding volume means you may need to take a little out until you hear the gurgling, put a little in until you don't hear the gurgling. You're trying to get the minimal amount of gas in there. And then you would record however many cc's it took you to seal the airway. Okay? Now, generally speaking, there'll already be air in the cuff, so you might only write 1 or 2 or 3 cc's, but that whatever it is they're recording. Okay, that's the minimal occluding volume. Okay, so you're listening for just sort of a laminar flow, no leak. You'll confirm it on your machine that your tidal volume has come back to whatever the set tidal volume is, and that your peak air pressure is back to where it was before, or not, at least not less than. It might be a little more, but it won't be less than. Okay? Minimal occluding volume. Now, the second way people use is what they call the minimal leak technique. Now, in the minimal leak technique, you need to use, in this case, you would use pressure. Now this is a manometer, okay? And also you would need a three-way stopcock. This is a three-way stopcock, okay? And when you look at the three-way stopcock, okay, this little handle, you get on it, says off. So when I turn it this way, it will tell you which way is off. Whichever way the word off is pointing, it will tell you that it's off. So in this case, it's off so that when I shoot air in here, okay, you might see the manometer move because gas is going into the manometer, but nothing's coming out. Okay, the next thing I could do is if I turn it this way, okay, nothing happens. You won't see anything. I can't get the syringe to move. The manometer does not move. Why? Because I've blocked off the syringe. If I put it so that it's off this direction, once again I'm going to push. Nothing happens on the manometer, but if you were to put your face right here, you would feel the gas coming out. Three-way stopcock. The easiest way to remember is to simply see which way the word off is pointing, and that's the way it's off. Now when you go to check your cuff, okay, you would need to have your little lever here pointing off down, because that means that all three of these are now open. You want to open all three of these. Okay? And then, once again, before I do anything, I would need to suction. And it goes without saying, I didn't say this, but it goes without saying, before you do any kind of procedure on any patient or anything, you need to have your manual resuscitator ready, you need to have a pressure checked, and you need to have the mask ready. In case you go to put air in this, the cuff blows, something goes wrong, you can't get it, you'll have to take the tube out and start bagging them. So you got to have your bag ready, always pressure check your bag, and have the mask ready. And that goes for whether you're going to suction, whether you're going to check a cuff. No matter what procedure you're going to do, that manual resuscitator is your best friend. Always have it ready, plugged in, and ready to go. Okay? Okay. So I do the mouth. I suction out the mouth again. Now I would attach the pilot balloon here. Okay. Once again, I would auscultate. Okay. Now this is the minimal leak technique. So the first thing I want to do is withdraw enough air to create a what? A leak. You all know the leak because I have determinate flow. It sounds like gurgling. I mean, it sounds like me on a bad day. That's the way it sounds. Okay? So then, what you would need to do is shoot in enough air until you seal the airway. Until you seal the airway. You get the nice laminar flow. Okay? Now, what I've seen happen is, I've seen through the years, I've seen students and they get there and they get their stethoscope and they're going really, really slow. Okay, now remember, as long as you create a leak, every time they get a breath, are they going to get their volume? No, not a bad move here. So I usually shoot a lot of air in first to make sure I get the leak so the patient can still be ventilating while I'm doing this process. Okay? I should look over, my volumes are back, my peak airway pressure is back to where it was, right? And then I do what they call as titration. I would simply withdraw until when? A leak, and then I would shoot a little air in until there's no leak. You go back and forth. Okay? Now this is the minimal leak. So what I want to do is get to the point where I have a seal, okay? And then I would just withdraw a little bit, because that would create a little bit of a leak, a minimal leak. And that's the pressure that I would record, minimal leak technique. Okay, how do I know I have the right pressure? Once again, I check here, I would look at my volume, I would look at my pressure. And that is recorded now in centimeters of water pressure. That's recorded in centimeters of water pressure, the minimal leak technique. The hospitals use a combination. Sometimes they'll shoot it in here, and remember with the minimal occluding volume, the idea was to seal the airway completely. So sometimes you'll get a combination where they say, no, don't leave a slight leak. Close it, seal it, all the way. And when in Rome, you do what the Romans do. but it's like learning how to drive, and it says 35 miles an hour, you go 35 miles an hour, and then, once you get your license, down you go 70 miles an hour, you do whatever the traffic's doing, right? Okay, so minimal leak technique, you leave a slight leak. You will get to the hospitals, they may say, no, seal it off, you do what you have to do in the hospital. Understand that. Okay, everybody's a little different on this. I'm showing you by name the exact technique, the way it's done. Remember, the hospitals they'll use combinations of all these things. Okay? Always, your best friend's going to be your heart monitor. Check your heart rate, check your saturation, check your blood pressure, make sure your patient's not desaturating or becoming bradycardia during this whole process. But your process really should be about as fast as this. This is as fast in real time as it goes. Name out. I put my stethoscope here. I would make sure that I turn it on. Okay. I will withdraw. I'm listening. Leak with my machine. I would put a little air in, get the seal. Once again, checking my machine. Withdraw, seal, and that should be it. Disconnect. And that's it. That's as fast as this whole process should take about a minute. Okay, you cut out all the talking, and that's how fast it goes. If you're sitting there going, going back and forth and back and forth, it's going to take it way too long. Okay? Any questions? Okay. The idea, once again, now, when you read in your textbook, it says the optimum pressure, as I believe it's 25 centimeters water pressure, should not exceed. It comes up sometimes if they've put a tube that is too small in your patient. If they've developed a slight leak, you may see where you don't get a seal till you get 50 centimeters of water pressure. The question is, what do you do? Well, what you would need to do is you would need to leave it at 50 and then call who? Call your preceptor right away and say, hey, it's taking me 50 centimeters of water pressure. Get a seal here. Okay? So they would know. Now, they may want to leave it alone. They may want to do whatever, but you have done your part and let the powers to be know that it's taking more than 25. Okay? Never withdraw to 25 and walk away, and the guy's gurgling and bubbling because they're not ventilating them. Okay? Your patient safety comes first. Make sure you call your preceptor. Don't say, by the end of the shift, 8 hours later, oh, by the way. No, you need to call your preceptor right away. Let them know right away. Okay? And we went through the whole business of what happens when you overinflate the cuff back in 174. Tracheomalacia, tracheostenosis, tracheoesophageal fistula. Okay, all those, you should know what those are. And underinflating, of course, now the patient can aspirate. You understand why their epiglottis is locked open, or they're not going to get their tidal volume. If they don't get their tidal volume, they don't get their minute ventilation. Now it's their what? What's affected? When you don't get the right minute ventilation, what gets affected?
PCO2.
PCO2. Okay? All right. Thank you.